The purpose of our study is to investigate the relation of serum levels of TNA and osteoporthyria of vascular stiffness and left ventricular diastolic dysfunction in patients with hemodialysis. Methods: we recruited 63 patients with hemodialysis HD from 2 different hemodialysis centers from February 2008 until November 2010. And then we estimated a serial, and we estimated certain factors, including the blood samples. The blood samples include vascular calcification regulators, which are phosphorus, ALP, alkaline phosphatase, parathyroid hormone, active vitamin D, 25-hydroxyvitamin D, vitamin A, and osteoporthyrin, and marker of myocardial fibrosis, which is procollagen type 3 internal amine peptide, which is called P3P. And also we assessed arterial stiffness by brachial ankle pulse wave velocity, BAPWV, and estimated aortic abdominal calcification by AHCS by CT scan using a Gadsden score. And we evaluated cardiac function by echocardiography, focusing on diastolic function parameters, which are left atrial volume index, LABI, left ventricular mass index, LVMI, and a reliable marker of diastolic dysfunction, the most reliable one, which is mitral valve annulus E over E prime. Results. Here, the general characteristics of our patients. We can see that 44 of our patients are male. The mean age is about 65, and they have a higher hypertensive, higher systolic pressure, 143 millimeter mercury. And our patients, 60% are smokers, 62% are hypertensive, and diabetes compromised, about 48%. So our patients are a bit high risk group among hemodialysis patients. And then regarding blood samples, in general blood samples, hemoglobin is slightly lower than normal values. And we focused on the markers of calcifications. As expected, there is a dysregulated markers of calcifications. Here we can see that phosphorus, alkaline phosphatase, and parathyroid hormone are slightly high, and 25-hydroxyvitamin D is slightly low. And marker of myocardial fibrosis, P3P, we can see it is higher than the well-known upper limit, and for the mean for 15A was lower than the mean normal limits as well, and osteoporthyria was higher than the mean normal limits. And for arterial stiffness, they have, as expected, they have stiff arteries and more calcification burden. And for cardiac function, we evaluated size, systolic function, and diastolic function. For the size, they have a hypertrophied interventricular septum, and posterior wall, it's a bit hypertrophied. And for systolic function, presented by ejection fraction and fractional shortening, it was preserved. For diastolic dysfunction, for diastolic function, left atrial volume, E over A prime, and left ventricular mass index were a bit higher than well-known controls. Then we compared, or we made a correlation of serum vitamin A and osteoporthyrin molecular parameters. Here, the blue color is a significant inverse correlation, and the red color is a significant positive correlation. Here we focus on our interest that marker of myocardial fibrosis, P3P, marker of arterial stiffness, or parameter of arterial stiffness, brachial artery pulse wave velocity, and aortic calcification, as aortic calcification score, they were all significantly inversely related to phenytoin A and positively significantly related to osteoprotein. In echocardiography, the systolic function presented by left ventricular ejection fraction has no relation to phenytoin A and osteoprotein. And the marker of diastolic dysfunction, E over A prime, which is the most reliable parameter of diastolic dysfunction, and left atrial volume index and left ventricular mass index, they were negatively related to phenytoin A, and with the exception of left ventricular mass index, they were positively significantly related to osteoprotein. And here we can explain in diagrammatic figures, we can see as I explained, the relation between left atrial volume index and phenytoin A, it's inverse relation, and with osteoprotein, it is a significant positive correlation, and phenytoin A is inversely overall, left ventricular mass index is inversely related to phenytoin A. As well as the marker of myocardial fibrosis, P3P, is inversely negatively related to phenytoin A and positively related to osteoprotein. And the most reliable factor of diastolic dysfunction, E over E prime, is negatively associated with phenytoin A and positively significantly related to osteoprotein. Then we made multiple regression analysis for E over E prime and related parameters. As I said, it is the most reliable factor for diastolic dysfunction. With phenytoin A, we can see that phenytoin A is independently associated as compared to other confounders with E over E prime. And osteoprotein also is independently associated with E over E prime as compared to other confounders. Then we have osteoprotein and phenytoin A. We divided each parameter into high and low of phenytoin A and osteoprotein, high and low, and then we examine this relationship with the arterial stiffness, and we can see that patients with low phenytoin A and high osteoprotein